The next session is we'll have 3 presenters discussing practice research and evaluation in respite care. But before I introduce them and hand it over, I would like to pose a poll question for everyone. We are interested in getting a sense of who all is in the audience. So if you don't mind using the chat box and for the other, and then answering the question here in the poll. It looks as if the majority has voted, so I'm just going to acknowledge that the majority of the people who responded are professionals working in aging or disability services. Looks like it's followed by researchers. I also know that we have some people working with children, including a crisis nursery director. That's near and dear to my heart. Those of you who know me know. So thank you very much. I appreciate your taking the time to respond to that poll. At this point, I would like to introduce our panel. I'm only going to give a brief introduction and let you know that their full bios, remind you that their full bios are in the packet. So we have Dr. Thomas Caprio, who is with the University of Rochester Medical Center, Sarah Swanson, who is an assistant professor at the University of Nebraska Medical Center, and Dr. Susan Jenkins, the Office of Performance and Evaluation for Center for Policy and Education at the Administration for Community Living. So I'm going to hand it over now to Dr. Caprio, and thank you.
Thank you so much, Cassandra. And thank you all for your interest in joining these last 2 days. And I'm thrilled to be able to present some of the work that we've been doing in New York State in partnership with our New York State Office for the Aging and our Community Aging Services Network partner, Lifespan. I know many of my colleagues and partners have joined us today, and really the credit goes to them for the hard work and efforts over many years that has brought us to where we are today with developing a volunteer respite workforce to provide support to the caregivers in New York State. Next slide, please. So you all know about Lifespan Respite care programs, and our goal in New York State was to continue to build the statewide integrated sustainable lifespan respite program and have that integrated into our long-term services and support system. And what I'm going to be talking about is specifically our objectives to expand our capacity in New York State, raising awareness across the state, and developing the volunteer respite pool of statewide individuals that could continue through a train-the-trainer model, be able to develop this volunteer respite workforce. Next slide. This gives information about our partners and our funding sources. We're very fortunate to have ACL funding. We also partnered this with HRSA funding, Health Resources and Services Administration. I'm the PI at the University of Rochester for the Geriatric Workforce Enhancement Program, which part of our focus is on caregiver education and training. And this allowed us to take and scale some of our training across the state through the Finger Lakes Geriatric Education Center. Our lead project partners are listed on the left here. The New York State Office for the Aging was our lead organization. I know that several of my colleagues are here today. I want to give a shout out to Jennifer Rosenbaum and Dina Prest, who really have been the fearless leaders of pushing forward this effort. In addition to Doris Green, who oversees the New York State Caregiving and Respite Coalition. This is a group of over 1,000 stakeholders in aging and disability services throughout New York State, and affiliated with Lifespan of Greater Rochester. And what I'm doing by pointing this out is that this is a very unique partnership, taking together state, federal, aging services network, community groups, and I'm going to talk about in a second this interface for me certainly as an academic partner, but I'm also a geriatrician, a clinician that works with both patients and families within this space all the time. And we use this to evolve into reaching out to faith-based partnerships and other community organizations to develop this lifespan respite workforce. Next slide. This outlines sort of a brief overview of the framework and structure of our evaluation methodology. And again, kind of reflecting this across to the positioning for future research that has come out of the ARCH reports. So in the planning phases, a lot of work, and this has really been through the partners with Monroe County Office for the Aging and Lifespan and the State Office for the Aging, of building the stakeholder engagement, putting together these academic, government, community partnerships, building the infrastructure so that we'd have the capacity to launch the training that has really gone across the entire state. And a lot of effort in recent years has been on sustainability planning. The implementation phases of this was really using a train-the-trainer model in which we were developing trainers that could then go forth and develop companion volunteer training, which I'll talk about in a little bit more, where this is the volunteers that were actually providing the respite services. We also, over years, have been growing a mini grant program in which was allowing community partnerships and faith-based organizations to develop respite drop-in sites so that we could expand upon the respite capacity across the state. And then the evaluation components included training surveys, both of the train-the-trainer programs as well as going through and the volunteer training to ensure that there's fidelity across this scaling and implementation across the state. We developed a caregiver survey to be able to do some assessment about the impact on the beneficiaries of respite care, which, as Dr. Washington talked about, is a lot of times really the caregivers, not just the recipients of the respite itself, but the caregivers that were able to free up some of their time by able to entrust their loved one to respite care. And then process measures for mini grant sites, I will show you in some detail about where we're at in terms of implementation at these sites. Next slide. So the model that we utilized was the REST program, the Respite Education and Support Tools. And this was an evidence-based design, train the trainer course to be able to create these REST companions. So in other words, and sometimes referred to as respite care workers or volunteers or the providers, these are the folks that are actually spending time in these drop-in respite sites with the individuals that were being enrolled in the respite programs. And the targeting for this kind of recruitment of where we are developing these volunteer workforces range from senior centers and healthcare organizations, area agencies on aging across New York State, the faith-based organizations, adult daycare, and other social service organizations. Next slide. The dissemination efforts was pretty extensive, and we have literally covered all of New York State at this point. There's development of master trainers in New York State, and that was the first time that we had that in New York State. So these are trainers that could then train the trainers. And the rest trainers, you can see the numbers here, 262 across all of New York State, offering rest companion courses to those organizations that were interested. Training well over close to 250 volunteer respite companions, over 10,000 hours of respite services provided for 730 caregivers served at this point. People come to the training from a cross section. So these are the volunteers that we're engaging as a volunteer respite workforce. They come from county agencies, faith-based communities, college students, university students, other human services organizations. And participants would attend the two-day training. In the era of COVID, this was pivoted towards online training to work to support those caregivers. Next slide. So this kind of gives you the framework of the three distinct areas I'm going to talk about in terms of our evaluation outcomes. The REST, the train, the trainer courses was producing qualified REST trainers that would then go on and be able to provide these services to organizations to build their volunteer workforce. We developed post-training participant surveys, again, to look at the fidelity of the training programs across the different training sites and tracking the number of trainers and the master trainers across New York State. The REST Companion course, this was the volunteer workforce that was being developed. We developed pre and post course evaluation surveys, and I'll show you some of those results about changes in terms of their level of confidence and concern in areas where they started to enter into these areas of REST training and tracking the number of volunteers trained as a process measure. And then finally, these respite drop-in sites, that was really operationalized through a pretty unique mini grant program that was allowing funding to go to individual sites for them to develop respite programs. And tracking with that, both the number of hours of respite provided at these individual sites, and I'll share some of that information with you, as well as we developed a caregiver post-respite care survey to get an assessment about what is the impact on the family caregivers by being able to participate in these respite programs. Next slide. So just briefly, this is the trainer evaluations. Just to give you a quick snapshot of the participant survey ratings. These are based upon 5-point scales, 5 being the higher score, and you can see the mean score is very positive from an educator standpoint. This is great. We were able to accomplish, I think, what we wanted to in terms of the satisfaction of the trainers. I want to go to the next slide now to show you the results of the companion course. So these are the respite volunteers that are being trained. And the important points to have in this slide is to understand these are pre and post surveys. So I'm showing you a mean change score of what their understanding or knowledge level of these particular areas are. And if you could click forward one step on the slide. I want to highlight these particular areas. These were statistically significant in the fact that there was an increase in the scores for the volunteers of learning how to really work with respite recipients, interests and abilities, the care recipients' needs, adapting the activities to those needs, understanding challenging behaviors, and dealing with injuries and emergency situations. These are one of those key aspects of being able to feel more confident and comfortable in terms of interfacing with these respite recipients as well. Next slide, please. Sort of a counterpoint to that is these are areas of concern that we surveyed with individuals at the beginning of the training and then afterwards. How concerned are they? So the lower scores or a mean change that is lower is actually an improvement in those areas. And if you could click one step on this slide as well. I'll put myself at risk for becoming ill was the most profound change. So we were allaying fears, if you will, of folks that of themselves getting sick or and somehow being harmed in terms of working with these individuals with respite care. Now the caveat and why I bring this up here is that how does this change in the era of COVID? And that's something that we need to sort of think about in terms of, we heard from Dr. Washington, a lot of respite programs and other organizations are really limiting or restricting those types of services at this point. So again, looking at building confidence and understanding about the interface with working with respite recipients, something that we just have to kind of put back as a footnote, I think, in terms of developing evaluation strategies moving forward. Next slide. This outlines the statewide respite mini grant program. So this is, we initiated in summer of 2016, and we did a series of stepwise recruitment and awarding of these mini grants to finally about 13 applicants. Each mini grant site got around about $5,000 to help develop a drop-in respite program. Not a profound, large amount of funding, but significant enough to be able to engage them in terms of that planning and the work moving forward. Next slide. These are the respite grant mini sites, the various sites and regions of the state that were being served with it. And I want to draw your attention to the different target populations. Some were just really focused on all comers of older adults with a mix of different kind of conditions and needs with it. Many were focused on dementia. Others were built around senior companion programs or specifically doing outreach to rural seniors. And I think this is very important. It's kind of has raised a question in my mind to be able to think about this in greater detail of the target populations and where the needs are, you know, and having even a targeted approach to thinking about the distribution of these types of programs on a statewide level of where's the greatest need and the populations to be served. You can see that the reportings that came out in terms of the companions that are being trained at various sites and the hours of respite services that were received. Down towards the bottom, these are our most recent additions to the mini grant program. You can see that there's 0 reporting numbers, and that is because most of these programs that were the new additions had been put on pause because of COVID-19. So this is one of the challenges, again, of conducting any sort of research in this kind of pandemic era, is being able to get that sort of information and resources over to the evaluation kind of strategy. And that does have impact in terms of the robustness of a lot of the associations and the data that we have. Next slide. We conducted the Caregiver Post-Respite Care Survey, and this is an adaptation of tools that are existing with Arch Respite, asking some very just basic questions about how did the caregivers perceive being beneficiaries of the respite program. No surprise, 100% of the respondents indicated that there was a reduction in their caregiving stress because of having respite care. which is not a surprise to me. There's probably response bias. If they didn't feel that they got benefit, they may have not responded to that. But what's really interesting, and this really hits home for me as a clinician, is that 80% indicated they have no one to fill in for them as a caregiver during an emergency. And so that's really profound of knowing that we really have this tremendous need. So you go to the next slide, please. This is giving some demographics of the breakdown of the caregiver respondents to these surveys. No surprise, a lot of times spouses, son and daughter, son-in-law or daughter-in-law. What intrigues me, and we didn't really ask the questions to delve into this, is who are the non-relatives that are involved in these kind of cases? So that's one area that I think that we need to begin to explore in a little bit greater detail. Next slide, please. One of the limitations that we have is certainly with the low reporting at many of our respite grant sites, particularly the later editions of them, is we've had this is the most recent kind of survey that we had just implemented. We have very small numbers of respondents at this point to the survey. So I'm reporting here is just 7 survey responses. We wish we had more at this point, but I think this helps to describe the examples of the methodology that we're using. I think one of the important things over on the left-hand side is the time period using respite care. So this is accessing the respite services there. Most were in a 3 to 6 month range, some up to a year period of time with it. And going back to Dr. Washington's talk about sort of the dose of respite, I think this needs to be a consideration. It's not just the frequency of accessing the services, but what is the time horizon that we are actually looking at the time period that people have been involved with a particular respite program. On the right-hand side is a mean rating of just a 10-point scale of reported caregiver stress perceived from caring for a family member. Again, very small numbers, so I'm hesitant to draw inferences from this, but it's trending in the right direction. Certainly a 1-point reduction on average from pre and post assessment of being a recipient of these respite services. Next slide. These were the perceived outcomes. Again, very small numbers, but the perceived outcomes of drop-in respite. No surprise, care recipient benefited the most. 100% said that as their response. But other trending areas that are important to point out is a sense of relief that caregivers felt. Worth my time and effort, high quality of the care, I'm able to continue in my caregiving role. This is a story of resilience that we start to see unfolding that allows people to be appropriately resourced to continue in their caregiving role and feel that their loved one is receiving the care they deserve and that they need in a safe and supportive environment. Next slide, please. And so wrapping this up here is the lessons learned from this. I think I tried to distill it down to 3 main points. One is that we could not have done this without leveraging evolving state and local initiatives all over the New York State area. Being able to engage partners in the area agencies on aging, the community resources, and that is going to be very important towards moving towards sustainability with it. The other lesson, and I think that this resonates with many of you that are working in or with organizations that are community-based, many of these are mission-driven partners that are very much focused on the implementation and the outcomes of feeling that they have been successful in what they have been charged to do. They are less familiar with some of the nuances of data management, reporting, and outcome assessment that is necessary from a research standpoint. And that has to be acknowledged because I think that is one of the big challenges that we have in terms of moving respite research forward. And my plug-in is that for academic institutions, we can be good partners with many of these community organizations to provide the expertise in program evaluation and survey design and methods that can report and enhance the reporting of these kind of outcomes. And that's been the really great partnership that University of Rochester has had now with the State Office for Aging and with Lifespan to be able to be a valuable partner. So thank you. I'm going to hand things over to my colleague, Sarah Swanson, and she will take over from here and we'll answer questions at the end. Thanks.
All right, thanks so much, Thomas. I guess I just want to start out and express my thanks to Arch and all of you. As someone that has served as a family caregiver myself and runs programs now that support family caregivers, I know firsthand how important respite is. And I think it's important that as we move forward, we can really quantify those impacts. So I'm going to share information about a project that we engaged on that started in 2015. When Nebraska received funding from the Administration on Community Living to evaluate the impact of respite, create a respite training program, and disseminate respite information through the university system and to other employers through our state. And I have to do a shout out right now to Sharon Johnson-Grow, who I believe is participating in this, this webinar. It was Sharon's vision that really was the reason that we had this project. So thanks, Sharon. The purpose of our evaluation was to gather as much comprehensive information about respite services in Nebraska and how those services were both received and provided. Family caregiver outcomes related to stress levels, health, mental health, employment, relationships, and finances were all explored and evaluated. In addition, respite providers were surveyed and provided information about their experiences related to service provision, training, and challenges in the field. And then finally, systems outcomes were identified and addressed as we were able. Next slide. The evaluation model that we used was Patton's utilization focused evaluation model, with the purpose being exploration, program implementation, and improvement, and improved outcomes for program participants. Actually, Dr. Jolene Johnson, who is an assistant professor at UNMC, was the lead PI, and my role was really to provide technical assistance to her. And I guess I was much more intimately involved in the program implementation and develop related to the respite training program and also the employer engagement projects. Next slide. So across the 3 years of our program or our project, several methods were utilized to measure both impact, and these occurred at multiple levels. These included with interviews with our statewide respite coordinators, surveys to both respite providers, and qualitative analysis through focus groups with scripted questions. Also, the distribution of online surveys and paper surveys at regional conferences, and finally, scripted calls conducted through our statewide respite coordinators. As we progress through the next slide, you're going to notice that data is displayed in terms of years collected, and when appropriate, it will be displayed in aggregate across all 3 years. If you want more information about any of the content that I'm providing, you can access this online through this report. It is going to give you a lot more details than what I am able to provide for you today. Next slide. Before I really dive into the specifics, I think it's really important for you to have some context about Nebraska. Nebraska is considered a best practice state related to respite. We have a state-funded program called the Nebraska Lifespan Respite Subsidy that was established in 1999 that provides a monthly subsidy of $125 a month to family caregivers across a range of abilities, disabilities, and chronic conditions. Additionally, the state has 6 respite coordinators who help connect families to both respite funding and also connect them to respite providers. And interestingly enough, it was Nebraska's program that really was the basis for our federal Respite Care Act funding. We also have developed a respite data dashboard that summarizes respite utilization across multiple programs and shows the total number of individuals receiving respite access across all of our state regions at any given time, and includes information about demographics, funding types, and respite duration as just some examples. I'm not going to discuss this today, but I personally feel this has a lot of potential for future research studies. Next slide. So when we look at the impacts of providing respite, I'm going to share some of our results of our surveys. Next slide. Related to family caregivers, across all 3 years of the study, the survey respondents found that respite care received by the care recipient was overall very satisfactory. 78% of family caregivers agreed that the overall level of respite care services was also satisfactory. However, you're going to notice that 47% identified difficulty in finding respite care providers. Next slide. So this next slide shows the level of caregiver stress in relationship to receiving respite. If you look on the very far right, you're going to notice that family caregivers who reported being extremely stressed decreased dramatically upon receiving respite care, down to 4%, which is a 32% decrease. And that this number significantly increased to 57% when they were asked what their stress level would be if respite ended. Next slide. So in the next 3 slides, you're going to notice that this is reporting on health outcomes to the family caregiver. And you're going to notice that the adverse health outcomes were much higher before receiving respite. So that's indicated in blue, but decreased upon receiving respite in red. So this is in year 1, next slide, year 2, next slide, and year 3, next slide. This chart shows the level of strain between spouses. The blue bar shows stress before receiving respite, the orange is with respite, and the gray is if respite ended across all 3 years. You're going to notice that respondents' stress decreased when respite was provided, but interestingly, across all 3 years, respondents indicated a higher stress level if respite were to be taken away. Next slide. Now this slide is particularly interesting to me because I think when we think about respite, we're typically looking at the family caregiver, and this is directly looking at the care recipient. The chart shows the relationship strain with the care recipient. And again, the blue bar shows stress before respite, the orange while receiving respite, and the gray is if respite ended. And once again, across all 3 years, the level of stress was higher if people were asked if respite were to be taken away from them. Next slide. So in 2016, it was determined that we needed to further explore mental health and employment issues. Therefore, a series of 5 questions were developed, and we asked our respite coordinators across the state to administer these through phone interviews to participants that were specifically receiving our respite subsidy program. There were 123 responses, and 30% of these indicated feeling sad or depressed for at least 1 week in the last month. 36% indicated feeling sad or depressed for 2 weeks in the last year, and 41% indicated that they felt sad or depressed most days of the last 2 years. Next slide. When answering questions specifically about employment, most of the respondents indicated that employment was really impacted by their caregiving responsibilities. Many couldn't even be employed. So therefore, the numbers that we report could be an underestimate of the true impact that caregiving has on their employability and the workforce in general. But when asked if caregiving responsibilities had resulted in missing or being late to work, 30% answered yes. So of these, 73% indicated they missed between 1 to 5 days of work, 11% indicated missing 5 to 10 days of work, and 11% both indicated that they missed between 10 and 15 days and more than 15 days of work. Next slide. So participants were also surveyed asking about whether they'd ever considered an out-of-home placement. Do you want to hit the slides a couple more times, if you will? If you notice, 24% were considering an out-of-home placement before receiving respite. This decreased to 7% once they started receiving respite. And interestingly, if asked if respite were taking it away, it increased to 27%, higher than even before they started to receive respite. One more advance, if you will. Okay, next slide. So in 2016, we surveyed our respite providers, and you're gonna notice that we had a total of 80 respondents, and 29% of these were from an agency, but 71% were independent providers. When asked a question as to what they considered to be the greatest challenge in providing adequate respite care in Nebraska. There was an open-ended response, and the greatest challenges were low wages, the gaps or the disparity that they saw between rural and urban regions of our state, and the need for enhanced training or strategies to deal with those that have more challenging behaviors or mental and behavioral health concerns. Next slide. So related to provider competence. Next slide. We developed our own training program for respite providers, which consisted of 3 parts. The first was an online training program that was interactive and had testing questions. The second was that we asked our students to go through a structured practica in our recreational therapy program, where they were able to have interaction with lots of individuals across all abilities, and also mentorship from our trained staff. And finally, and what I really think is probably the most critical part, is we gave them a practicum in a family home. We employed a family caregiver respite coach. That's kind of a mouthful. But that person really allowed the students to come into her home and talked about how they had made modifications to their home to allow that the child with the disability to be successful. They talked about their concerns about having people come into their home and what they would need to do to make them feel comfortable. And the coach really tried to generalize this across the lifespan, if you will. And I can tell you, as we surveyed our students, the home-based respite was by far and large the students' favorite part. And when we tried to get this incorporated into college programs like CNA training programs, the home-based respite was the part that they all the instructors talked about as being important, because they couldn't replicate it. And more care is being provided in home and community-based settings. So next slide. When we talk about systems change that improves respite access, one of the things that I want to point out is that as a direct result of this evaluation, our state leadership made changes to our respite subsidy program, including a higher allocation for crisis respite. So those individuals that were already receiving respite could receive $1,000 instead of that $125 to kind of meet the exceptional circumstances that family was undergoing. Can you advance the slide, please? One more. Okay. So providing respite education and outreach to employers was something that we found to be very, very, very effective. And so we hired a respite employer engagement coordinator, and I actually think she is part of this webinar, Kim Falk. She just did a wonderful job in providing outreach and educating employers. We first started our outreach efforts through the University of Nebraska system, which is interestingly one of our largest employers in the state. And then Kim worked with several of the respite statewide coordinators across the state to identify additional employers that we could do targeted outreach with. They were very instrumental in educating employers about the needs of working family caregivers, including how they often have to drop out of the workforce or reduce their hours. They provided specific examples of what employers could do to better support their working family caregivers. And they also kind of helped them recognize that many of their caregivers or their employees probably fall in that sandwich generation where they are caring for both their children and their aging parents, and how this is not going to be a topic that goes away, because as our population ages and we have less people to provide care, this is increasingly going to impact their workforce. Kim was very instrumental in reaching out to mid-level managers, did outreach to the employee assistance programs and wellness programs, and she really directed them to help their employees get connected to respite resources in our state. So some of the problems that we identified through this is that there really was a lack of understanding of what respite really was. They were uninformed about the working need or the needs of working family caregivers, and they didn't really know about what respite programs were available. Next slide. This is a great picture of Kim in one of her employer new hire orientations. But we were really able to do a lot of great things. We created a website of statewide respite resources. And in the first year, we only had 90 visits. But in year 2, we had over 641 visits. And this has really remained consistent. So I personally think that this is something that we should look at because it really is a way to increase awareness of respite, and using employers, I think, is just a great strategy. Next slide. So now as we move forward, kind of some of the things that we're working on right now is that Kim, as her role as an employer engagement coordinator, she is going to be working to disseminate the Wisconsin survey. That is a survey that's been developed to evaluate the well-being of working family caregivers. And Kim is really going to work through our existing relationships that we have through the university system and the other 80 employers we have across the states. Next slide. Additionally, UNMC Munroe-Meyer Institute has been contracted by our state to administer the National Core Indicators Survey. And we are looking at ways to incorporate a couple of questions related to respite specifically. And I guess with that, I'd like to end this and turn the presentation over to Susan. Thank you.
Thank you. And thank everyone for the opportunity to speak with you today. My name is Susan Jenkins, and I'm the Director of the Office of Performance and Evaluation at the Administration for Community Living, which is part of the U.S. Department of Health and Human Services. And I'm here today specifically because I was the federal technical representative overseeing the evaluation of ACL's National Family Caregiver Support Program and leading the effort on ACL's learning agenda, which covers 2020 to 2022 and is focused on caregiver services and caregiver programs. So I'm going to talk a little bit about what the National Family Caregiver Support Program, NFCSP, is, the evaluation, and then talk about some next steps in terms of research that we're doing and research topics that we're interested in. Next slide. The NFCSP provides grants to states and territories that fund various different supports to help family and informal caregivers care for older adults in their homes for as long as possible. There's also a part of the program that focuses on grandparents or older relative caregivers, but this study focused on caregivers of older adults. Next slide. And these are the services, the 5 services that support the key areas of improving caregiver care, that support caregivers, and working with resource centers to enhance positive systems change. Those are some of the things that we were looking at to do with the evaluation. Next slide. So the purposes of the evaluation fit nicely with the key areas of improving caregiver respite care, particularly related to system change, and improving access to respite services, and the focus on individual, family, and societal outcomes. And so I'll talk a bit about the outcomes today. We also did a process evaluation which focused on how the program works, and that information is on the ACL website, and I have a link to that later in the presentation, along with all of the results from this particular outcome evaluation, which focused more on the outcomes for the caregivers themselves. Next slide. So the data were collected through a survey of nationally representative sample of caregivers and comparison group members at 3 points over a 12-month period. Consumer level or caregiver level data were analyzed and matched with programmatic data from the service providers to link information of program features with information about what seemed to work best for the caregivers themselves, and to help us better understand which system elements are associated with access and positive outcomes from the program. Analysis of the baseline information showed that among the more than 1,500 caregivers that were surveyed, their mean age was 66 years old. And at baseline, 43% of them said that they received respite care within the past 6 months, mainly in their homes. And among those, the median number of respite hours each week was 6. Among the caregivers who said that they did not use the respite services, so they received other NFCSP services, but those that said that they had not used respite in the past 6 months, approximately 1/3 said they didn't use it because they didn't know about the services. And so the previous presentation talked about education to teach people that respite services do exist. The next most common reason was for not obtaining needed respite care was that they didn't qualify for the services, the various different local programs. If you can go back to the previous slide, please. The various different programs have different criteria. And the third most common reason was that the caregivers didn't actually need that service. They used some of the other of the 5 services that are offered through NFCSP. If you can go to the next slide now. The reported odds ratios for respite care means that the probability of a caregiver responding more favorably to being able to continue offering caregiver services in the community increased 4.7% for each hour of respite service that they received. So it's not just a question of do you receive respite or not, but there starts to be a question of how much respite care do we need to really start to make a difference. So in other words, caregivers in our sample with the fewest number of respite hours were more likely to say definitely no to the continued caregiving question. They were maybe not able to continue caregiving. And those with the most respite hours were more likely to say definitely yes, they would be able to continue providing care in the community. Among caregivers that had used respite in the previous 6 months, as the number of hours increased, so did the probability of a more favorable response to the question of, have the services you received from the local agency enabled you to provide care longer than would have otherwise been possible? And when caregivers who use the respite services were asked how helpful the services from the local agency were to them as a caregiver, 98% of the caregivers said that the service was very helpful or somewhat helpful. So these responses are very similar to what we've been hearing in the other 2 presentations. Next slide. These data shown here, which are also explained more in the final report, show that people receiving the NFCSP services relied less on supports from friends and family and slightly less of the respite services, receiving slightly fewer respite services or lower amounts of respite services from other organizations, suggesting this does fill a need. And we may want to do more research. We may be able to do more research with our population, particularly in the area of if people receive respite and they're then less likely to rely on friends and family, does the benefit of respite care not just affect the caregiver, but also affect that larger community of friends and family, that larger circle? Next slide. Another key finding from our difference in difference analysis was that on average, program caregivers who receive respite services of 4 or more hours per week had a decrease in self-reported burden over time, while the comparison caregivers who did not receive the services reported an increase in caregiver burden. So it's not only that our caregivers showed a decrease in burden, but otherwise they may likely have had an increase in burden over that same time point. And so the findings suggest that burden may be particularly sensitive to the amount of respite care received, and that there may be, as I mentioned, a certain minimum amount of care that is needed to reduce the burden. Next slide. And so in terms of key research areas, ACL intends to use the research findings from this evaluation to improve technical assistance and other supports to NFCSP grantees and to continue to monitor the service recipient outcomes. In terms of next steps of what ACL is looking to do around caregiver services, the Older Americans Act, which funds ACL's National Family Caregiver Support Program, was reauthorized in January, and the reauthorization goes through 2024. Thank you for changing the slide. The Act mentions caregivers in several places, including with regard to ensuring that they're consulted in the development of objectives, priorities, and long-term plans for supporting state and local efforts involving the education about the prevention, detection, and response to negative health effects associated with social isolation. The Act also mentions activities for increasing business acumen, capacity building, organizational development, innovation, and other methods for sustaining the capacity of the aging network, which involves states, AAAs, which are area agencies on aging, and local service providers, helping them to build that sustainability to serve older individuals and their caregivers effectively. And the reauthorization also does continue to fund the NFCSP program with an additional focus on caregiver assessment, assessing the needs of caregivers and matching them to the best services, the services that are best for them. Next slide. And our learning agenda, which I mentioned at the start, those are now required by law for federal agencies, certain federal agencies, and they're a driving force between helping us to really publicize what kinds of research are we going to do. And they help us to plan and identify the research that we're going to do, what we're going to do with that data, and share that. They encourage sharing that with the field so that other researchers can best partner with us in these areas. Next slide. And so the priority question for our interim learning agenda, which runs through 2022, is what is the efficacy and effectiveness of the ACL programs, but with a particular focus on the sub-question of, is ACL being effective in its caregiver support programs? And so we really will have an intense focus on caregiver programs across the lifespan over the next 2 years. Next slide. And so in terms of our current efforts, we have a number of things that we're doing at this time. We have an evaluation of the home and community-based support services for our older American Indian, Alaskan Native, and Native Hawaiian populations. It's a process evaluation that is completed and an outcome evaluation. We expect to have the results available in the summer of 2021, and it doesn't focus solely on caregiving, but caregiving services are part of those what we call Title VI grants. And we also are currently finishing up an evaluation of the family communities of practice for the Charting the Life course. And it's an evaluation, a retrospective evaluation of a community of practice looking at how systems work with individuals with developmental disabilities and support those populations, their families, and their caregivers. And those results should be finished sometime this fall and posted on the ACL website. Next slide. So we have a few new efforts that we're funding. We're looking at doing a topical module on caregiving for our National Survey of Older American Act participants. So we haven't developed those questions yet, but we're looking at doing that to then survey all of the Older American Act participants for the selected services about caregiving needs, understanding of caregiving, things like that. We haven't written the questions yet, so we haven't determined the exact focus. We're also looking at doing a process evaluation of the aging network. Who is in the aging network? What do folks do? How do different partners work together? And we will in part focus on caregiving. We're doing a fidelity evaluation of evidence-based programming, and a number of the evidence-based programs funded through the Older American Act deal with addressed focus on caregiving services. And we've recently started a flexible evaluation contract that allows us to, at a moment's notice really, fund research projects, quick turnaround evaluations related to numerous topics. And a lot of that will be focused on the topics for our learning agenda, caregiving. Next slide. And so with that, I want to say thank you to everyone for participating in this. And I believe that we have time for questions. So I will turn it back to our facilitator for this session.
Thank you so much to all of the panelists. And before we move on to the Q&A section, we have a poll question that is related to the last topic. And that is, which of the following do you believe is the biggest obstacle to employers' limited responsiveness to family caregiver needs? So if you could take a few moments and respond to that poll. Okay, it looks as if most people have responded, and I am a little bit surprised that financial impact on organization is not the highest, and that's heartening actually. But what we're seeing is the most responses came in lack of awareness of caregiver needs. That's something that is probably we can respond to easier than responding to the financial impact on an organization. So thank you so much for sharing that with us. I just so enjoyed the panelists. Dr. Caprio, just a few before we move into the questions. The fact that only 80% you mentioned of the caregivers that were studied had no one to help without respite. So without respite, no one else was there. And as someone who has been a caregiver to two very close family members, I used to think to myself, because I did have family and friends that provided me with a lot of respite, and I used to think, what on earth do other families do who don't have those supports? So that was very interesting to hear. Also, I wanted to mention to Sarah Swanson that Dr. Kirk and I created a survey many years ago. It's probably 15, 16, and maybe as many as 20, I don't recall. But we found the same thing is true, that when caregivers were asked if we were to remove respite, if you didn't have it anymore, we found that people's stress levels and the family discord, the caregivers were predicting that it would be far greater than the stress at baseline. So you get respite, things get a lot better, but the very thought of losing the respite really increased. So we were seeing the same sorts of things many years ago. Also, Dr. Jenkins, it resonated with me, the whole thing about dose. We've talked a lot about dosage and respite, and I'm going to be very interested in future findings related to dose and effectiveness of respite care. So thank you so much to the three presenters. I am going to look at questions, and I want everyone to please feel free to put the questions in. And I'm also going to ask Kim, I can read them, but we have so many comments here scrolling up and down. You might help me if I miss any. So.
Sure. Do you want me to read them, Cassandra? Or
I'm saying if I miss any, but I'd like, we hear that smaller, so this is Cheryl, some of these are comments. We hear that smaller employers are willing to accommodate a worker with caregiving responsibilities, but won't make it a policy available to hold employers or to use for recruitment of workers. So that's a comment more than a question, but I'm wondering.
There's a question earlier, Cassandra, from Sarah Swanson. She asks, respite is a required partner in aging and disability resource centers. Is this funding stream being considered to evaluating respite impacts?
Yes. So the evaluation of the NFCSP was particularly an evaluation of that program, but through the learning agenda, we're including all parts of ACL. And so aging and disability resource centers will be part of the larger caregiver focus for our evidence building activities, as will be some of the work done in our National Institute for Independent Living, Disability and Rehabilitation Research, and the other various lifespan respite programs that ACL funds. So the ADRCs, the No Wrong Doors, were not part of the NFCSP evaluation, but will be part of the efforts related to the learning agenda evidence building.
There's also
one of the questions, were you going to say something, Sarah? Sorry to interrupt.
No, I was just saying awesome, thank you.
And this is a question for you anyway. So did Nebraska reach out to small business associations as well? And if so, was it successful?
So I don't believe that we reached out to the small business associations, but we did reach out to SHRAM, which is the State Human Resources Managers Association. I think I got that right. Kim Falk, you can jump in here if you like. We also reached out to the Department of Labor, our American Job Centers. So we were trying to engage it at multiple levels. Kim, is there anything you want to add?
You know, we encourage, I mean, I do have to thank my partners of the respite coordinators from the Nebraska Lifespan Respite Network in reaching employers across our state. We did develop this program with the role of the coordinators in mind, so we could keep it cost effective and reach employers across the state without a lot of travel time and mileage and things like that. But our coordinators reached employers in their areas that they may have known, maybe part of their advisory committees, or even some of the other caregivers that they've already been lined up, that they already work with, including the organizations or the businesses where they were housed out of. So we had a lot of contacts through that. There were a few cold calls that were made from certain, to certain businesses that they thought were key players. We did also use the university system, contact the university system, as Sarah mentioned. So we have University of Nebraska Medical Center, University of Nebraska at Lincoln, at Omaha, and at Kearney, which also led us to a lot of other businesses as well. Reaching out to our Department of Labor offices was interesting. We just did that in our last year, and I will just mention it was really different for the Department of Labor offices I had contacted prior to COVID and after COVID had started. But I did hear a lot of interest from, maybe not with sharing respite resources, but definitely with finding employment for individuals, even on a part-time basis for individuals who wanted to be part-time respite providers. So that was a great partnership through our Department of Labor offices with that, but we'll keep going.
And another question, we have time for a few more, and this is to pretty much all of the panelists. Is there any sense of what the lower end of the optimal amount of respite might be? And this could be some speculation, but anyone want to tackle that?
I'm happy to start off and have other people chime in. In our research, we knew how many hours, or we asked people how many hours of respite they were receiving, and 4 hours seemed to be an important point, that under 4 hours was really not showing the benefits, and 4 hours and more, that seemed to be the sort of breaking point. And the more hours that people received, they still continued to receive more benefits, but 4 hours for us, for our population, for our study, which is limited, seemed to be the number.
Thank you. What I would like to suggest now is that for the questions we were unable to answer, if the presenters would respond to them in the chat box if they have the opportunity, because we're ready to head to our break.